So, welcome everyone to this week's medical grand round at Flinders. Great pleasure to have Michael Bagent, who I'll introduce in a second. But to start, we've got Di Lawrence as EDMS, who's going to give us an introduction to Crazy Socks. So, Di.
Thank you, Jonathan. Hello, everyone. This is a really timely grand round because tomorrow is actually our annual Crazy Socks for Docs Day, and it's a day where we really stop and think about doctors, our own wellbeing, mental health, and all that of our colleagues. So I just wanted to give a bit of a plug as tomorrow morning in the courtyard here at Flinders Medical Centre and at Noarlunga Hospital in the boardroom, I'm putting on a breakfast for doctors, co-sponsored by John Mannion from Breakthrough Foundation. So that will be from 7:30am till 8:15, and we've chosen that time so that we can also get some of our doctors coming off night shift and those coming onto the day shift. So there'll be coffee, tea and croissants, and I look forward to seeing some of you there first thing in the morning. We'll do it obviously as a takeaway in a socially distanced, meeting all the guidelines. So thank you, Jonathan.
Thanks, Di. You have to wear crazy socks to get a croissant, or but anyway, please go along to that. And in keeping with that theme, Michael's going to talk to us today about doctors' mental health, and I think particularly all the strains and stresses that have arisen around COVID. Michael will be known to many of you. He's a professor in the Department of Psychiatry here. He's got particular interests around addiction medicine and gambling. I won't go through his impressive contributions to Beyond Blue and New Access and others. I'll just go to the last paragraph of his introduction. He says he wants to write a book called Is Surfing an Addiction? Reflecting his personal interests, but his friends have discouraged the idea, fearing that he would lose all professional credibility. So anyway, Michael, over to you, and keep up your professional credibility with this grand round.
Oh, thank you.
Thanks very much.
Thanks, Jonathan. Thanks for the opportunity to maintain my professional credibility. It is a great pleasure to come and talk today, the day before Crazy Socks for Docs Day. And I'd like to reveal that I'm in fact wearing crazy socks, but I'm not going to do a calisthenic and bring my leg up so you can see them. But I'm wearing one red sock and one sock that's got sharks on it, which will become relevant shortly as I go through the talk. Anyway, so I'm going to talk about doctors' health, doctors' mental health, and COVID, and I'm going to really frame it in two sections. The first section is going to be about doctors' mental health before COVID, and the second bit's going to be following the impact of COVID on mental health, doctors' mental health. So now, mental health of doctors BC, as I've called it before COVID. The image down here, underneath that heading, the photograph there, I hope some of you recognise, it's a scene of calm at Amity Island in 1975 on the 4th of July. And in the background, I think you can see Officer Martin Brodie, played by Roy Scheider. This is the beginning of the scene of Jaws, the movie Jaws, which is now 45 years old. So I'm choosing that kind of metaphor, and I hope you forgive me for this. So today's talk is going to be somewhat lighthearted, but with a serious undertone. So this really depicts for me, the mental health of doctors before COVID. So I'm just going to talk a bit about it in general terms to begin with. Now this slide's very important. And it's very important for us when we're working that the symptoms of mental illness or our mental health is actually on a spectrum. And at any moment, we might be experiencing emotions that are very, very normal. We can have sadness, happiness, distraction, anxiety, and so forth. Then, if we're thinking about this model a bit further, there's the level of reacting. And when you're reacting, it's a very normal response. It's adaptive in many cases, or most cases adaptive, that's why it's there. But you're reacting to a situation. It's not mental illness. It's reversible. It goes away quite quickly. An example of that might be you're presenting at the grand round and you feel a bit anxious about doing so. It's a very normal, reactive sort of emotion. The next level up is injured. And this might be something like you've been put on leave, you can't work, you've lost your income, it has an effect on your mental state. You feel distracted and sad, anxious about your future, you're not sure what's going to go on or what you're going to do. When you go back to getting to working again, those symptoms go and it's alleviated. So you're sort of injured in a way. And finally, there's ill. And ill is where you have persistent symptoms and you're disabled and you're not your usual self. Now, as doctors, it's important to think about it in this way, I think, because we want to be very clear when we're reacting to something, when we're injured, and also when we're ill, in which case we need to do something about our mental health and either get treatment or get help or do something ourselves, but to take some action. I'm just going to talk a bit about burnout, because burnout's very much something that doctors are aware of and like to talk about. And in this spectrum, burnout fitted in between reactive and injured. And burnout, I remind people, is a term that was first coined by an aptly named psychiatrist, Dr. Freudenberger, in 1975 in San Francisco, when he was working in a community clinic and him and his colleagues were just overwhelmed by the work. And eventually he noticed that people reacted in a particular set of ways. They felt exhausted physically and emotionally. They developed a sort of a callous, remote concern about people, and we could define that as cynicism. And they viewed themselves as being incompetent. What's the point? We're not making a difference, all that kind of thing. And there were also the reflections of what it's like when someone's experiencing burnout. If you're unsure what that's like, and I hope you haven't experienced it, but if you're unsure what it's like and you want to get a good feel for it, I'd suggest you read The House of God by Samuel Shem. And that is a great depiction of what it's like. In fact, the main character becomes quite burnt out and in the end really quite mentally ill. It can be a precipitant to mental illness, of course. If I'm looking at what we know about the prevalence of mental disorders amongst doctors BC, before Corona, I'm going to refer to the best source of evidence for that, and that was the Beyond Blue study that we did in 2013, where we surveyed a large number of Australian doctors. Over 12,000 responded, and we had all sorts of findings. I'm just going to go through a few of the key findings from that research that are relevant. First of all, a lot of doctors do rate themselves a score on the measures of burnout in the burnout level. And this shows the percent of doctors who scored high on the scales of burnout measure. And it's stratified according to age of doctors. What you'll instantly see is that approaching 50% of doctors can experience burnout in the different ways of looking at it. But the burnout is really experienced mostly by our younger doctors. And I think this is really important for us to be aware of, and when we're thinking about our colleagues and what we can do, especially us more senior people, to be aware of the burnout experience of many of our younger colleagues and keep an eye out for them. I haven't got up here the gender split, but higher rates are experienced amongst female doctors than males. The good thing to look forward to, of course, is that if you look at the tan or the khaki colour graphs, bars, you can see that we've all got a great fun time to look forward to once we're over 60, because life in medicine becomes a lot easier with far less burnout. And in fact, I'm looking forward. I'm not quite there, but I'm getting there. I'm just going to pick out some relevant findings from the research. This is the percentage of doctors by specialty who self-reported ever being diagnosed with depression in their lifetime. And it breaks it down according to a different area. And as you can see, there's a spread from surgeons, 13.8% ever reporting being diagnosed with depression, the lowest group, through to doctors who work in the non-patient area, such as research and administration, having the highest levels of ever being diagnosed with depression. When you look at it that way, there are some of our colleagues than others more likely to have been diagnosed with depression. Now, it may be a good thing to be diagnosed with depression, because that means you're having treatment for it. it might mean that there are more surgeons on the whole that are not getting treated who should or do require treatment. But they're interesting findings nevertheless. Doctors are actually not too bad at seeking treatment for depression. About 2/3 of them do seek treatment for depression, but they're not as good as at seeking treatment for anxiety disorders. Only about 1/3 of doctors seek treatment for anxiety disorders, which is pretty hopeless. Anxiety disorders are very treatable. If we're looking at the current levels of depression amongst doctors, and we've got the gender split, we see that on the whole, females report higher levels of current depression than the general population, and males roughly about the same. Doctors are not immune to mental disorders just because we know about them. We looked at the sources of stress for doctors, and I think this is very relevant when it comes to thinking about COVID, and COVID nor even thought about as being included as a is a pandemic a big source of stress in a day-to-day life for a doctor in 2013? No, well, it wasn't. But what was conflict between career and family responsibilities. That's the big thing. The other big thing is too much to do at work, and I think that really kind of relates to the first one. Bullying wasn't high up on the list in our survey, but it was if you're an Indigenous doctor. The other thing is that speaking in front of an audience, this is something I think that a lot of the time we don't realise is so much part of the career, but it is. There is a lot of performance involved in being a doctor. You have to perform. We might be giving a talk. You do often have to perform in front of a ward round, for example, or a group of people in other ways. So speaking in front of an audience is something that can be quite difficult for a lot of doctors, and if you've got a social phobia, it's particularly challenging. Suicide. What we found in our survey, looking at people who've had thoughts of doctors who've had thoughts of suicide in the previous 12 months. There were two. Probably, the cut was psychiatry, emergency medicine, anaesthetics, and non-patient, and the lesser group, the group that had lower rates, were surgery, and all the others you can read it down the page. So there was a slight differential. The rates of thinking about suicide are maybe surprising to you. Thinking about suicide doesn't mean that you're going to act on it, but it can be an indicator of being in strife for sure. It needs to be taken very seriously. I'm now going to talk about COVID and mental health, and you may have spotted that the scene at Amity Island has changed. There's panic on the beach now, and obviously the metaphor or the comparison I'm drawing is between Jaws, the shark out there, and the COVID, and we're on the beach, and we're the swimmers on the beach. I mean, the reality is that COVID is a threat to doctors. If you catch it, it can have a bad effect on your health. It can be fatal in small percentages. As doctors, we are dealing with not only the threat to ourselves, but also with our distressed patients and with the staff that are around us. This can have an effect on us. What has happened with the COVID, and it's come home to everybody, is that our world has changed. Our view of the world has also changed with that, and it forces many of us to confront our own mortality, whereas before we might have been able to avoid that. Being preoccupied or being aware of your mortality is one of those existential fears that we all have as humans. We all, of course, know we're going to die eventually, but it's just not now. We might be thinking that we're invulnerable. The people that face the dangerous things are the doctors that work in the Congo or something like that. But now the reality that if you ask people to report on a pen and paper, they'd probably say yes. Of course, there are risk times being a doctor, but they really didn't think it was likely to affect them. Now that is reality. So we are thrust into that precarious and anxiety-provoking situation of knowing that we are potentially at risk. That is the reality. Whereas before, we've been able to walk around happily avoiding the thought and the knowledge of that. COVID, the effect of COVID is that it can shift where we're sitting on that spectrum I was talking about before. So, and here's a shot of Amity Island just after panic on the beach. And they're all clustered around something that was very unpleasant that was brought up on the beach, about part of a body, I think it was. So it can shift us. It can shift us from injured into illness. It can shift us from reacting into illness or into injured. It can shift us all in many ways down this end of the spectrum. It could also shift us into the healthy or be an enlivening experience for many of us. And in a kind of an unusual way, COVID has brought about a potential for greater autonomy, and we're being forced to think of creatively and of new things we could do to get by for the betterment of our patients and our staff. We have perhaps been able to exercise a greater degree of autonomy than we would normally have done before. We have to act, we have to do things. We're not being bogged down by process. We can instantly get on to do things. It also brings us together a lot more. With my team, I've had the pleasure of putting in place something we didn't have before, but it's a weekly kind of get together virtually with all the staff, from admin through to clinicians, where we kind of just get together and talk about stuff vaguely related to our work very briefly. And so the number of these things have changed and come into play, and that can actually invigorate some people if that is your temperament. But it can head the other way, and we're likely to head the other way if we have a particular temperament, pre-existing temperament, particularly one that leads us to feel anxious and to be fearful of risk and change and uncertainty. If pre-morbidly we're strongly obsessional, as most doctors are, it can be quite a difficult thing with all these things happening around us. And if you've got a pre-existing illness, this sort of pressure and stress can actually intensify or worsen your condition. I wanted to look at what we know about the mental health of doctors from the research evidence after COVID. But I've got to say there's not a hell of a lot published about it, as you'd predict. I mean, it's so recent. And mental disorders following trauma usually peak at an onset at 3 months. They don't happen immediately. If the symptoms are there immediately, this is a sort of these are responses in reaction to the stress. So the actual evidence for it is pretty scant and far between. I mean, interesting, the Japan Times published an article on the coronavirus effect on Europe's medical staff. I thought that was an interesting thing, and in that article there are all sorts of nifty quotes. In Belgium, studies indicated that more than twice as many healthcare workers than usual had thought about quitting the profession, and levels of unhappiness were about 4 times higher. I couldn't find any of this published, I've got to say. I looked very hard, but couldn't find any published in peer-reviewed settings. Alcohol consumption skyrocketed. 70 calls a day from medics in crisis in France. Imminent risk of suicide calls on helplines, and so on and so forth. So there's a lot of reporting, but there's not a hell of a lot of evidence. There was one paper I saw of a cross-sectional survey done of staff in a hospital in China, and that was quite interesting. It showed that 14% of the 1,500 odd health workers scored in the problem range on symptom measures. But the interesting thing for me particularly was that, and this fits in with other research on pandemics prior to COVID-19, was that those who had emergency department experience were the healthiest psychologically. And it says something about I'll talk a bit about that in a minute. But when you look at research from prior pandemics, such as the 2003 SARS one back then, the H1N1 in 2011, first of all, there's not a lot. but when you do look at it, there are some common themes that come out and some interesting relevant findings. First of all, affecting doctors, particularly headlining, are the fears of contagion and the fears of contaminating their own family and loved ones. Comes up very high. The percentage who scored in the illness range, or likely illness range, in these non-diagnostic screening scales were between 20 and 35%. A really relevant finding was that support negatively predicted psychiatric disorders as outcomes, meaning that support was a helpful thing in reducing the likelihood of that happening. And there was one 2-year follow-up looking at the incidence of mental illness amongst doctors who had been through I think it was the H1N1, and they found that that the incidence of mental illness in doctors was lower or perhaps similar to the community baseline rates of people who went through the similar crisis. But I just want to talk a bit about this idea or this model. Really, you've got to think about it in this way. It's a realistic fear, realistically dangerous experience, the COVID. We are all geared up to react to dangerous situations by experiencing fear and wishing to escape or avoid it, or to fight it. But often escape and avoid is the overriding thing. For us, it can lead us to feeling like leaving the profession, and that was reported in some of those studies I looked at. But it can certainly lead to people having feelings of anxiety and depression, if not leading to them developing disorders of anxiety and depression, and I'll go through what they are in a minute. On the counter side to that, the balancing side to that, is managing, and this comes about as a result of resilience, which is thought to comprise of, or measurements have it as comprising of a tendency to be able to cope, employ tenacity, and develop and maintain optimism. Training is an important part as well, so being prepared, knowing what to do, being rehearsed in how to respond. Experience goes with that as well. Social support, and if you're crook or overwhelmed, doing something about it and getting some treatment so you can manage. So I think there's a balance really between the threat that's posed by COVID and those factors that can have an influence. I'm just going to talk a bit about a few of the mental disorders that are likely, and about how they might present and appear in this type of setting in doctors. But first off, there's a normal... the best part of the DSM-5, which is the new Diagnostic and Statistical Manual of Mental Disorders, which is a list of psychiatric diagnoses, which we all love. The best part about it is a section that under the heading called Normative Stress Reaction, where it says something profound like, when people are put under stress, it is normal to react with a stress reaction. Kind of, I'm paraphrasing it. So it says that when you're facing something that's pretty bad, it's normal to have features and symptoms of it. I think that's really important for us to remember. It doesn't mean that you've got a mental illness. There are things you can do to look after yourself, obviously, but it doesn't mean you've got a mental illness. Mental illnesses can be precipitated and exacerbated by this type of threat, however. And we can get a whole raft of the depression kind of presentations. And if you're interested in the diagnoses we might give in psychiatry, might say an adjustment disorder with depressed mood, where the person doesn't have all the features and symptoms sufficient to warrant a diagnosis of major depressive episode. Their impairment is probably not as bad, but they can still be affected. They might find it hard to go to work, might be teary at times. Major depressive episode is a profound and distinct change from where you were before in your mood. You're preoccupied with kind of characteristically depressive symptoms, mood, thinking, suicidal thoughts from increased, and it affects your biological functioning in the ways you would know. The anxiety spectrum and anxiety can be a symptom of depressive disorders as well. It doesn't mean you can't have anxiety as part of that. Anxiety problems include an adjustment disorder with depressed mood. So you adjust to this stressor and your anxiety is disabling you beyond what would be expected and affecting your day-to-day work. Generalised anxiety disorder is generally not precipitated by these sorts of things because it's usually been there before, but it can have been under control, but then with this pressure that's put on top of you, you can be overwhelmed with it. Generalised anxiety is the tendency to be overwhelmed by worry and the physical symptoms that go with it. You worry about things, particularly that are going to happen in the future or could go wrong in the future. You're plagued by catastrophising thoughts and what-ifs, and it can get you to the point where you're beyond the point of functioning and you can't think clearly. Illness anxiety disorder is what we used to call hypochondriasis, and obviously the corona symptoms are quite vague and non-specific to begin with, and people who are preoccupied with the fear of developing a medical illness can be troubled and really overwhelmed by the whole prospect of is it corona, and we'll be seeking reassurance from doctors and so forth that it isn't, or looking for ways themselves to get reassurance that it isn't, or they will be trying desperately to avoid anything that brings up the whole notion of corona and illness, and they might find the very mention of it anxiety and panic precipitating. Acute stress disorder and post-traumatic stress disorder, they're kind of very closely aligned. Acute stress disorder is where you've got a major life-threatening stressor and then you react in a characteristic way. Typically you're troubled by memories of it, they distress you, nightmares, the reminders of it really are concerning, and you would like to avoid anything that reminds you of it. Now, we're fortunate here in Adelaide because the people that might have had that kind of exposure are few and far between, because we've been spared, thankfully, from the horrors that, say, Spain or Italy or America have been faced with. Post-traumatic stress disorder really needs to be those sort of symptoms persisting beyond a month and really disabling you and so forth. So we wouldn't be expecting that to be affecting our doctors at the moment in relation to the COVID. Anxiety is normal, reacting is normal, but there are times where we do things to manage the anxiety that are actually making it worse. And tending to wish to avoid anything that takes us anywhere near it can make it worse. The COVID and the reminders of COVID are going to keep popping up all the time, and it's very hard to avoid it. And the more you avoid it, the greater the fear becomes, and things get worse. The other thing that people can do to maintain the anxiety is by thinking that they'll get the answers on the internet for their anxiety. There's a big difference between having to protect the community and research what is important to know in relation to your patients and your own health, and looking up the internet for reassurance to try and manage that anxiety, as if there's an answer somewhere in there, in something you're going to find that's going to make you feel that your risk is not great or that it is not as bad as everybody says it is. The trouble with that is that you for every bit of information you find that it's okay. For example, Donald Trump says disinfectant is going to cure it. You'll find all this other evidence that says that's wrong and it's not, and so forth. And you can't constantly be looking things up either as a way of managing your anxiety. Otherwise you'd be glued to the screen 24 hours a day, which is often what happens with people, which does not help them to cope or to feel better. Hypervigilance is another thing that maintains it, always being on the lookout, like Roy Scheider here. He was, this is before the shark attack. Unfortunately, he knew there was a shark out there on the beach in Amity, off Amity Island. There was a bloke that came down to sit in front of him. He sat in front of him to talk to him about something that was going on. And Roy Scheider is completely distracted the whole time. He's popping over, looking over the shoulder the whole time, trying to see what's going on the beach. Vigilant, hoping he can spot it before it happens so he can avert it. Similarly, when his wife is trying to have a conversation with him, he's still sweating and preoccupied, watching the beach, or the internet, I suppose. And in a way, given for us the COVID virus has been and is still a potential threat, but hasn't actually, it isn't actually affecting us yet. It's the thought that we have about the potential effects that really drive a lot of the feelings that we have. We have to be alert and obviously do things to prepare, but we can be lost in the thought of endless catastrophes that could befall us, and live that every day, even before the worst things possibly happen. So there could be all sorts of catastrophes happening down the road, but if you're constantly thinking that that's going to happen, it's going to happen now, and that kind of thing, you're going to live that feeling and experience that feeling now and every day until it actually happens. And what's the advantage of doing that for you and people around you? So the other thing that's worth noting is that style of thinking that there's an answer somewhere, I've got to find it, and we need order and control, is something that we learn as doctors. We're trained to become obsessional. If we're not obsessional when we go into medical school, we are beaten over the head with the obsessional stick. We have to learn to be obsessional, because otherwise, if you don't follow the steps, people will die. You've got to be very thorough, not miss anything, don't make a mistake, otherwise life's going to be lost. Well, that's true. And that kind of thinking leads us to be primed to want to find the answers desperately, and to try and regain some of that control for ourselves personally, when it's probably not possible to do that. Norman, or Saint Norman, as I think he should be called. He's done a wonderful job. He's one of the best communicators out there on medical things. I've met Norman a couple of times. He's a really nice bloke, but very earnest and sincere and very worried, I might add. Norman, I don't know if he's still doing the COVID things, but I haven't been switching on a hell of a lot to the COVID things. One of the things that that we could be doing, and this is kind of imagery to get us thinking about the need to constantly get information and gain it and all the rest of it, is that we're attracted by signals that suggest danger. We look at them preferentially. We screen out other things, so we focus on that. That's important to protect ourselves. We do that for survival. Those attentional changes maintain our anxiety, and we having it all the time is kind of like keeping us at that level. So I'd encourage us to let Norman bear the brunt of the endless searching on the internet, and he can present it all to us in his bite-sized podcasts and present it to us very, very well with that slightly depressive manner. I quite enjoy listening to Norman. He's really good. Interestingly, people have thought about what we can do in the face of a pandemic, and there was this really good prescient paper that I read, published in 2011, and it was published by people from Mount Sinai in Toronto, and they were talking about after the SARS pandemic in 2003, they said, we've really got to prepare for another pandemic, because if we were to think about the worst possible outcome, there could be doctors getting sick, there could be hospitals overrun with patients that we can't cope with, there could be people not turning up to work because they're too afraid, there would be the population decimated with illness, and we've got to be prepared as hospital to respond to that. And the things they described in this paper, which was written back then, really captured a lot of what a lot of the worst places have gone through now. So I think it's quite interesting. But they went through an approach which involved groups and both a hospital-wide approach to improve the preparedness of staff to manage a pandemic should it arise. And then lo and behold, in 2011, that's when the H1N1 pandemic did come, and it did affect the hospital. And I wish they wrote up an evaluation of what impact the training had on the staff following that, but they didn't, unfortunately. But what happened following the initial preparation, they wrote up, they described the improvement in confidence the staff had in managing a pandemic, and it was a remarkable increase in confidence in managing a pandemic following their approach. Essentially, they set about, without going to the specifics, they set out some principles which helped it. The first principle was to hope for the best and prepare for the worst. The second principle was understanding of a normal stress response, and I hope that I've covered that a little bit in what I've talked about today. about the spectrum of reactions and how it's a very normal reaction to fear to want to keep yourself safe. They talked about coping strategies. I went into that in quite a bit of preparedness and sensible detail, and they got down to even looking at things, well, they identified problems that might arise. It took a problem-solving approach. A problem that might arise, for example, is what if your family gets sick and you have to look after them? Well, I know what we can do maybe is we can immunise them against all other possible illnesses to try and ensure that all the bases are covered for the families of the staff. And so they really took a very sensible approach to it. They developed, knowing that the evidence from prior research that support reduced the likelihood of people getting crook, they set about developing a culture that was supportive. And they also were very, very ready and sensible in acknowledging the value of the wisdom of the crowd, where you set off an idea, you talk about stuff, and then you're very open to people's feedback on how to improve it and so forth. And through that way, things, it really evolved into what was a really effective, or seeming to be a really effective, intervention. So, last slide, what can we do? Well, we can, first of all, make sure that we work in an environment in which we are supportive of our team and we value them. We secondly, I think, need to be very aware of the importance of training, having some experience, some almost hardening experience, but rehearsal, because this leads us to feel confident that we can handle situations. I'm not really, like most of us, I probably don't like all those enforced training things you've got to do all the time. But I guess if we don't know what we're doing and we're prepared, we'll have greater ability and confidence and comfort in actually doing what we've got to do should the problems arise. I think it's important for us to think about too the important role and the meaning of the role that doctors have in the community. We often get a bit cynical about what good we're doing or whatever, but we do have an important role, and this COVID threat has underlined that important role, really. And we are putting us, I suppose we are, there is a degree of threat. And why do people do that? I've got no better explanation than that's kind of what's involved with being human, really. We just do that for the better of the group and the herd. So my own little add-ins very much remember humour is good, keep it going. Look out for that catastrophising rabbit hole. You can choose not to step into it. And keep your eyes out for your workmates and your colleagues, and certainly, above all else, look after yourself as well. So thank you for your attention.
That's great, Michael. Thanks very much. Hope you just take a few questions.
Yeah.
I hadn't been aware that younger colleagues are a bit more prone to burnout, or there's a greater prevalence of burnout. Can I ask you a very practical question? So, let's say I had a junior colleague I thought wasn't flourishing, and I was a bit worried might be experiencing some burnout. Would you guide us in any way about practical steps to take to connect them to care, to connect them to help? I mean,
Yeah.
I suspect many of us are bad at it.
Yeah.
That we don't reach out, that we don't go to them and say, have you thought about
Yeah.
seeing someone around stress?
Yeah, no, that's a very good question. I suppose the first thing we tend to do is to, and there's a literature on this, and we tend to blame the person in a way. We sort of say, well, that's not me, it's you because you're weak, and thank God it's not me too. But there's something you're not doing that's faulty or whatever. But that we can't take that approach. That's not helpful. It's not true. So the first step would be to talk to the person, to understand their experience and what is going on for them. And if there are practical things that can be put in place to help, I think that's a very important thing to consider as well, like common sense stuff. Practical workplace-related approaches. In my field, for example, our poor registrars were, and I hope are not still, but maybe under the impression that after hours they had to do the full bells and whistles Maudsley history written up beautifully and perfectly in the computerised patient record system. And if they didn't have that done, they would be caned the next day. And that that meant that it was just impossible for them. And really, we could and we can explain to them that what we expect is a much easier and more practical initial assessment, make their lives a bit easier. So there's also practical things you might be able to put in place. I suppose that the second thing is that being supportive of them and setting up maybe demonstrating an interest in setting up a kind of a process of checking in on them and how they're going would be useful and is useful, and even sharing some of your own experiences and how you can what you've found to be useful. You've got to temper that with the old, when I was a lad, this is what we used to do. We used to, sleep in the road and eat coal for breakfast. You've got it easy, all that sort of thing. You don't want to slip into that. It's very tempting to. But really to reflect on what you find a useful, helpful approach as well. Then if you do, you can open the dialogue with them as well about the difference between reacting to the circumstances, recognising the pressures that are at work and at home and the crunch between them, and just sort of asking them to reflect a bit about whether that's the situation, whether they could be crook or ill, and to think about that, and if there's any likelihood or possibility, then encouraging them to see somebody to get assessed for that. And the assessment could start with a GP, or it could start with a colleague, that you trust and know in the hospital. Mm.
Thanks. Di's had to pop out, but she's got a sort of related question, which is, why are doctors less likely to seek help for anxiety as opposed to depression, do you think?
Yeah, that's a really interesting. I think, first of all, there's a population tendency for that as well, and that's because we tend to see anxiety as a personal failing rather than a disorder, and we don't recognise that that overwhelming social anxiety is not just shyness. I mean, there's a spectrum. Some people are more shy than others, but being awake for weeks ahead of a talk you've got to give, sleepless, because you're so worried about it, is an indication it's a social phobia. But people seem to think that's weakness rather than an illness or a disorder that can be treated. Similarly with other anxieties like obsessive compulsive disorder, which a lot of doctors do have, as opposed to the personality type. This is where you have a recurrent thought that causes you anxiety and distress. You recognise as excessive, and you try to do things to alleviate it. And for doctors, often the obsessional doubt or fear of causing harm through making a mistake leads people to check repeatedly or to be slowed down because of over-checking. And they might not see that as being an illness, but they also might be ashamed of it. And that's a real common thing as well for that disorder. People are probably more likely to hold off if they've got PTSD because they feel that everyone else seems to be coping and not affected by it, but I am. And for a lot of the time, the trauma associated with PTSD can be a very personalised thing, and one trauma will affect one person but not affect another person because of the person's life experiences. So that those sorts of variations can happen. Yeah.
You talked about how many of us work in teams, or perhaps all of us work in teams in some way, but with COVID we've all moved to these Zooms or WebEx or team-based video sessions, and whilst those might get some of our meetings to run more efficiently, they clearly lose aspects of personal interaction and collegiality and so on. Do you think that's a real issue as we go through COVID and we've lost those personal connections?
Yeah, I think for some reason when you're on the phone, there's two sides to that. One, for some reason when you're on the phone or doing a video conference chat with somebody, you don't need, people feel safer in a way. So that, because I think the distance means that you don't feel as vulnerable and so forth. So people might in disclosure and participating and so forth. So on the one hand, there's that benefit, and they seem to be happening more inclusively, more frequently. So there's benefits there. But I do think there's a missing element of being able to read a person, see their non-verbals going with what they're saying, that makes us feel that we've really connected. So I still value face-to-face encounters and meetings with people very much, yeah. And I do look forward to when they'll be coming back, yeah.
I guess one of the issues that's come up for people heavily involved in treating COVID has been the issue of moral distress. So this issue that you might have resource constraint, might not be enough ventilators to ventilate everyone. For some people in more leadership roles, because of, oh goodness, I'm sending this team of more junior doctors out to a somewhat risky, dangerous situation, or medical students to be exposed or whatever. You reflect on moral distress as an issue through COVID, or am I overdoing that?
No. I think I can see, particularly where it's frontline, there are frontline issues. The moral distress issue would be profound because there'd be conflict between the ideas of individual versus group, and it throws up all the kind of the ethical issues about that reflect that, and it's a very understandable thing. And to some extent as well, there would be survivor guilt in there as well, where you think, well, I don't have to do that. Thank goodness I don't have to do that. But hang on, those poor people do. And how can I resolve that conflict that I'm sending other people to do something that I would feel anxious to do myself? So I think that the way we deal with the only way I could imagine to deal with that is to I think we shield ourselves and protect ourselves with procedures to follow that in a way that distances and allows us to rationalise. But I think doing it with other people and being supported in your decisions and being able to talk through the anxieties that you have, whilst at the same time being aware of the very truth which is that a lot of the time we do things that are tough for the greater good, and that's just a human reality.
Look, thanks, Michael. That was great, and please just encourage everyone to think about their colleagues tomorrow, well, and every day, but mark it particularly tomorrow, and have a croissant and look at people's socks. Yeah. You said we were allowed to end with humour, or humour was important. So, look, I'm sure we'll all be buying your book, Is Surfing an Addiction? But you might want to avoid some of those Amity Beach illustrations in it, I think.
Yes.
So, look, thanks again, Michael, for a great grand round.
Thank you.
Thanks.
Thank you very much. Thank you.